cornea and uveal diseases. There were 7 webinars related to Dr. PKC sir free paper competition. This year also we will be having Dr. PK Chatterjee sir free paper competition in the month of July and August. So we'll request the postgraduate to start preparing their papers very soon. We'll be coming with the dates. Today we are having a program on instruments. This is the first class on instruments. We'll have one more class on instruments. In this class, this webinar, the first presentation will be by Dr. Somodip Majumdar. He will be talking on non-phaco catered instruments, followed by Dr. Purban Ganguly. He'll be also speaking on non-phaco catered instruments, followed by Dr. Rudra Ghosh. He will be speaking on phaco-dynamics and phaco instruments. We are very fortunate to have Osim sir, Director RIU, chairing the session today, and Dr. Manoj Banerjee sir, Professor, Head of Department, Arjigar Medical College, is co-chair along with Dr. Moshmi Banerjee Madam, Head of Department, Bardwan Medical College, and Dr. Sambuddha Ghosh sir, Professor, Department of Ophthalmology, Calcutta National Medical College. So we'll request our moderators to please take over the session. If there are any questions, you can put it in the chat box. We will take the question at the end of all 3 presentations, and we'll request everyone to please keep their microphones muted so that we all can listen to the presentations. Suman sir, Sumanda.
Thank you, Manish. Actually, this is the first instrument class for PG education program, and this class is mainly based on the cataract instruments, the both phaco and non-phaco instruments. The non-phaco instruments are mainly dealt with by Dr. Somodip Majumdar and Dr. Purban Ganguly. Both are assistant professor of Regional Institute of Ophthalmology, Kolkata. And last but not the least, our very own Dr. Rudra Prasad Ghosh, assistant professor, Rampurhat Medical College, will speak on phaco-dynamics, phaco instruments, and also vitrectomy, in short, on vitrectomy instruments, because this is very important for your theory portion and we don't want to break the flow. So first we'll complete the presentations and after that we'll go for discussions. As Dr. Manish Singh has told you, you just put your questions on chat box. We'll discuss every questions. We have a very good panel of teachers with us, Professor Osim Ghosh, Director RIO, with Professor Manoj Banerjee, Professor Moshmi Banerjee, and Professor Sambuddha Ghosh. Both are taking the DO and MS exams for last very few years. So you will get good number of questions from this session. You just continue to listen the topics first and put your questions on the chat box. Now I request Dr. Somodip Majumdar to start the first portion of non-phaco instruments. Somo.
Thank you, sir, for giving me this opportunity, and we are very much thankful to OSWB PG Education Committee for giving us this opportunity to discuss the instruments, and it is very important for the postgraduate examination. And me and Purban, we are presenting in front of our very respected and very favorite teachers. And so today the topic of our discussion is the instruments for cataract surgery. We will discuss about the instruments which are instruments other than phacoemulsification, or the instruments used other than in phacoemulsification surgery. So first we have 2 very important instruments for every surgery, in every intraocular surgery. That is a eye speculum. One is known as universal metallic eye speculum and another is Lieberman eye speculum. Both are universal because both of them can be used in either eye. And universal eye speculum and Lieberman eye speculum, both are used to keep the lids open during any eye surgery. And the basic difference between these 2 instruments, because is that in Lieberman eye speculum there is a screw at the end of the speculum. This is a screw, and through this screw it will help us to have the desired exposure of the surgical site as per the surgeon's choice. And because of that, to have a better exposure, we usually to usually tighten that screw, and at the cost of this, we will create pressure on the eyeball, and this affects the intraocular pressure. That increases the intraocular pressure during surgery. So it is not advisable in open globe injury repair cases, and it is actually during cataract surgery we have faced a similar problem. When we have entered into the eye, sometimes in order to get a good exposure, we tighten the screw, and intraocular pressure rises and AC becomes shallow continuously. So during that situation, we should look for this thing, and we should lose the screw, so that the intraocular pressure comes to the normal again. So uses of these two instruments are almost similar. All intraocular eye surgery, cataract surgery, glaucoma surgery, retinal surgery, keratoplasty, in conjunctival or foreign body corneal foreign body removal, when there is a severe blepharospasm due to that irritation of the corneal nerve endings, examination of the ROP babies, and examination of the eyeball in the children, and examination of the patients with severe blepharospasm other than the foreign body removal cases. Now the second one is the superior rectus holding forceps. It is a tooth forceps. Here a tooth, there's a tooth forceps. The tooths are can be seen very nicely, and here is a guard in that middle part of the shaft of the limb. And here are few openings in that shaft. The openings are mainly in all the eye instruments. The openings are mainly made due to just to make the instruments lighter and have a better grip. It is tooth forceps. It has a S-shaped curve, specially designed to fit into the orbit while trying to grasp the superior rectus muscle belly, and it is used to pass the brittle suture through the superior rectus muscle, which helps to make our the eyeball in position during intraocular surgery, so that eyeball does not move and we can have a better grip. The Saint Martin tissue forceps. The Saint Martin tissue forceps is a widely used, versatile, and non-locking tooth forceps with a wide handle having horizontal striations. You can see the striations, and here you can see the tooth also. The striations are mainly for the better grip and control. It is widely used in our every surgery, and all the forceps, you can see there is a area. There is a area in that in the shaft where one projection of the instrument is just keeping that other limbs away from it during that holding of any tissue. So it is used to grasp or retract the conjunctiva in any surgery, holding flaps of sclera or cornea during any suturing, stabilize the eye while performing intraocular surgery, and we use it to perform surgical iridectomy also to catch hold the iris. McPherson's forceps. I will request everyone to just remember the spelling of this McPherson's forceps. And here you can see also there are 3 holes in that shaft of the limb. That is just keep that instrument lighter and for better grip. It is a fine, sharp tip non-tooth forceps with an angulated end. That angulation is actually almost 8 to 10 millimeters away from the tip, and it is mainly used to holding intraocular lens while inserting the lens in SICS. There's a rigid IOL, holding suture while tying the knots, suture removal, budding of the suture, loading of foldable IOL into the butterfly cartridge, and caterpillar hair removal. Another similar type of forceps without any bend, that is, we call it suture tire or suture tying forceps. The uses are almost same, but that suture tying forceps has no bend like this. Here we have a bend almost 8 to 10 millimeters away from the tip of the instrument. This is a Bart Parker handle with a replaceable surgical blade. Here 15-degree blade has been attached with that Bart Parker blade handle. It is a reusable flat handle intended for combined use with replaceable surgical blades for varying shapes and sizes, and it is used in cataract surgery mainly in the scleral incision in SICS, that is a small incision cataract surgery. First plane has been made. We usually made it with it. We usually make it with this instrument. And in trabeculectomy also, the scleral flaps are created, and the first incision is usually given by this instrument. And It is also used in skin incision, giving the skin incision in lacrimal surgeries and lead surgeries. Now, the side port entry blade, it is a straight knife with a sharp tip and cutting edge on one side. Here you can see that the one side has a cutting edge and the tip is a triangular. If we can insert, you can pass the longest diameter of this blade, we will have an entry of a 20 gauge caliber, and it is used to make paracentesis entries into the anterior chamber during intraocular surgery or any hyphema drainage or any intracameral procedure, and it can be used in also suture removal also, and creation of the lacrimal sac and nasal mucosal flap in DCR. Crescent blade, you can see there is a blunt tip knife with a bevel side of the knife positioned upwards. It has a cut splitting action on both sides. You can see the beveled edges, and it is a blunt tip knife, and the angulation which is here, it is almost 30 to 45 degree, and actually these angulation is made just to have a surgeon's hand and surgical site coordination, so that we can place the blade nicely on the sclera, and we can dissect the scleral flap in SICS during the sclerocorneal lamellar dissection. This is a second plane of the tunnel creation, and it is also used in trabeculectomy, dissection in the pterygium surgery, corneal dissection in anterior lamellar keratoplasty, and it can be used in contracted socket treatment during conjunctival incision and dissection. This is a keratome. It is a thin blade with a diamond-shaped or triangular apex and cutting edge on both the sides. It is a sharp tip instrument, and the angulation is almost 45 degree from that tip shaft and the tip, and it is available in various sizes. This size, actually, this is the length of the base of the triangle of the blade, and it is used to make a self-sealing corneal incision in cataract surgery. In SICS, for small incision cataract surgery, we made the third plane with this instrument, and in phaco emulsification, with the help of this instrument only, we can make a biplanar incision on the cornea. In keratoplasty, it is used to that is the removal of the recipient's preparation of the recipient's bed, and it can be used in making the side port entry in SICS also. Here we can tell one thing, that is during your identification of the instrument, never judge the instrument with that polycarbonate shaft color. Don't judge the instrument with the color of the polycarbonate shaft, because we have a picture of that the crescent having a green color, but in the instrument table you can get a crescent with a pink color shaft, and you may have a keratome with a green color shaft. So don't go to the color of the polycarbonate handle, go for the tip. The disposable cystitome, it is prepared with a 26 gauge needle attached with a 2 cc or 5 cc syringe. Some surgeons prefer to take water or viscomet inside the syringe, just to make have a heavy instrument in hand, so that it will be easier to handle the instrument, as it is a light instrument. And if the rhexis goes outside, then certainly you can put some visco and make the anterior capsule flat. So here you can see there are two bends of a 26 gauge needle, and the bends are actually the needle tip. We usually bend the needle tip down while holding the bevel up and maintaining this needle position. The needle is bent near the hub in the opposite direction. The first bend usually make it near 90 degree, and the second bend usually make it 45 to 60 degree to have a curved needle like this. And it is used to make anterior capsulotomy or capsulorhexis in SICS or phacoemulsification surgery. It is also used to primary posterior capsulorhexis initiation in pediatric cataract surgery, or central posterior capsular opacity or plaque, which is usually noticed after cortical aspiration in cataract surgery. And the second instrument by which we can do the capsulorhexis, that is the Utrata capsulorhexis forceps. This forceps has a fine titanium tip with a sharp point that enables to initiate the capsular tear. Then the capsule tear margin can be securely grasped to perform the capsular exis, and it has an iris stop platform that is almost 8 to 8.5 millimeter away from the tip. And this is the similar thing I have already told you. That is it is that iris stop platform at 8.5 millimeter from the tip to stop the shaft of the forceps from completely closing and damaging iris when the tips are opposed to hold the capsule. Thank you. Now just I will hand over the session to Dr. Purvan Ganguly to carry forward.
Thank you, Shomadip. I thank OSWB for giving me this opportunity. And Shomadip, when I say next, you just keep changing the slides.
Yes.
So I will continue with the most important, the scissors. We'll start with the scissors. The Castroviejo corneoscleral scissor is a universal corneal scissor. It's a fine curved scissor which is used to enlarge the cornea or the sclerocorneal incision when we are performing the conventional ECC, or earlier when they used to do the intracapsular cataract extraction. It is the principal use nowadays is also in keratoplasty, and it is also used to do peritomy. But the answer when the examiner asks you about the uses, you will say, sir, first use in cataract surgery. Cataract surgery, two types of uses. It is used in ECC to cut, conventional ECC to cut the cornea. In SICS, it is used to do peritomy. And in non-cataract surgery, the principal use in keratoplasty. Always divide and give your answers. Next slide, please. So this is the next, which is a smaller scissor. The size of the scissor is smaller than that of the corneal scissor. It's called the venous scissor. Be careful about the spelling. Sometimes the examiner asks you to write the spelling. It's a finer scissor. The principal use when the examiner asks you will be to cut the anterior capsule. When the examiner will see in what condition you need to cut the anterior capsule, then the answer will be when there is anterior capsular plaque, or if the capsular axis has run over, to start the capsular axis at a different site. And please, at the end of when the examiner keeps on asking what if there is any another use, then you say about the sponge vitrectomy. Next slide, please. So this will be dealt with in details with Dr. Rudra Prasad Ghosh will deal about it. But an overview, this is the Sinski's hook or the IOL dialer. So you can see that there is a confusion between the dialer and the chopper, especially with the blunt chopper and the dialer, it becomes confusing. So whenever you are handed over with the Sinski's hook or a chopper, be careful, take your time, see the tip, and then you pronounce the, the identification of the instrument. Now, when you ask about a dialer or a Sinski's hook, that what is its use, it's better to divide that use in small incision cataract surgery or conventional ECC and use in phacoemulsification. And be specific when you say about conventional ECC and SICS, that is to manipulate the nucleus from the capsular bag into the anterior chamber and to dial the IOL, PC-IOL from the anterior chamber into the anterior capsule. And in phacoemulsification, it is also used to rotate the nucleus after hydrodissection. And another use is also for lens delivery, that is to take out the lens from the anterior chamber into the exterior by sandwich technique with the help of a Vectis down and a Sinski's hook up. Next slide, please. So this is a chopper. Now we know that it is used in phacoemulsification to augment the nucleofractis. It will be dealt in detail with by Dr. R.P. Ghosh. Next slide, please. So this is an iris repositor. We all know it has a flat blade. But usually the question that has been asked about iris repositor is it routinely used in cataract surgery? The answer will be no. Then the examiner will say in what condition you use an iris repositor. The first thing is that to reposit the iris when there is an iris prolapse, when there is a problem with the wound construction in SICS or in phacoemulsification, when the intraocular pressure is very high or you have a floppy iris, then the iris tends to come out to reposition the iris. And also in cataract surgery, sometimes we use it to release the posterior synecdoche when we are dealing with uveitic cataract especially. And in non-cataract surgery, to tuck the donor cornea under the host cornea in keratoplasty. This is the way you should divide and say your answer so that you can elicit more questions. Next slide, please. This is a vectis. A vectis is this is a wire vectis. It consists of a metallic handling and a wire loop at the head. So what are the uses of the vectis? Be very specific. The use of the vectis is to take out a prolapsed nucleus from the anterior chamber into the exterior. And it is also used in cases of subluxated lens, and in sometimes in small pupil when the nucleus has not prolapsed into the anterior chamber completely, we use the vectis to go below the iris above the anterior capsule to take out. Next slide, please. So this is another form of a vectis, which is an irrigating vectis. In an irrigating vectis, there are small holes in the tip of this wire. And we usually attach a 5cc syringe or a 10cc syringe at the back in this opening. And while taking out, while doing the manipulation of the nuclear prolapse from the anterior chamber, water comes out from these small openings, and this coats the nucleus and protects the endothelium. So, remember that these small openings have a diameter of 0.3 millimeter, but sometimes it may be 0.4 millimeter also. These are the openings. Next slide, please. So this is an hydrodissection or irrigation cannula or lacrimal cannula. It may be 25 gauge or 26 gauge. The gauge of the cannula will be written here. So you identify it and you say accordingly. When they'll ask you for the use, you divide it into some diagnostic uses and some therapeutic uses. Therapeutic uses are in cataract surgery, in hydrodissection and hydrodelineation, and in or in the stromal hydration of the ports, and or to give certain drugs to augment the cataract surgery. What are the drugs that can be given? That may be trypan blue, that can be viscoelastic substance, that can be pilocarpine, that can be adrenaline. This is how you divide and say and give your answer so that you can augment more and more questions. And diagnostic use is in syringing of the lacrimal sac when you're suspecting a block. Next slide, please. So this is very important. Most of the cases, either you are given a crescent blade or a keratome blade or a side port blade or a Simcoe irrigation aspiration cannula. The gauge of the cannula will be written. It may be of 23 gauge or otherwise. And you see there are two ports. One is the smaller port and the other is the port attached with the pipe. So the port that is attached with the pipe is used for suction, and the port that is directly attached with the tunnel, with the cannula, is used for irrigation. And at the tip, there are two openings. The opening at the tip of the port is used for irrigating, and the port used at the side, tip of the port is used for suctioning, and the port at the side is used for continuously irrigating. Now there is another, and the principal use of this thing is to take out the cortical matter after the nuclear management has been done in a case of cataract surgery. Now there is another which is called reverse Simcoe or indirect Simcoe, where the longer port, the port that is associated with the tube, is used for irrigation, and the port that is directly attached with the cannula is used for aspiration. But the normal Simcoe cannula or the direct Simcoe cannula, if we change the ports, that is, we are attaching the longer port with the irrigation and the shorter port with the aspiration, will not get converted into a reverse Simcoe, because even in the reverse Simcoe, the tip will be used for aspiration and the side will be used for irrigation. Next slide, please. I'm extremely sorry for the spelling. That is a typographical error. The Vanus Caesar will have two N's. Thank you, Manoj sir, for pointing it out. I'll end with some tips and tricks. You always know that there is always a hurry. After giving your short case, you are compelled to sit for the instrument table immediately. So do not jump into conclusion. So always keep your composure and calm when you sit in front of the examiner. When you are handed over the instrument, take your time. No one wants you to jump into the identification of the instrument. First, you identify the instrument yourself. Then you say the instrument on your mind. And then you utter the instrument. The full identification of the instrument has to be done. And please be clear about your pronunciations and try to be phonetically accurate as far as possible. And always give answers in constipated fashion. Give the answers in bits and pieces. Always give the uses divided into therapeutic and diagnostic uses. Therapeutic uses in cataract surgery, non-cataract surgery, cataract surgery in SICS or conventional ECC, and phacoemulsification. This way you can invite more and more questions. And the last thumb rule is do not contradict the examiner. I will end with these words that giving the examination is just like running the chariot. If you are running the chariot, then you will make the examiner go to the arena where you are comfortable with. But if that is the reverse, if you're letting the examiner ride, then the examination will be difficult for you because you cannot learn or memorize everything and start and come to give your examination. Thank you so much.
Thank you, Purban and Shomo, for your nice presentation of non-phaco cataract instruments, and particularly your points and stress on particular points which to be told in the examination and which not to be told. Now I ask Dr. Rudra Prasad Ghosh, who is our also editor of our journal of OSWB, to take the mic and discuss the phaco instruments in brief. Rudra.
Thank you, Dr. Shuman Mukherjee. I'm going to tell something about the phacoemulsification. I have 5 short videos about the setting up of a phaco machine and how a phaco machine works, the principles, and some instruments that are specifically related to phacoemulsification. So I am going to share my screen of my first video. So you can see this is a peristaltic phaco machine, and I'll start from the beginning how a machine starts.
Rudra, is still not shared.
Hello?
Is not
It's not coming.
Just wait.
Yeah.
Just stop share. Yeah, it's coming now. It's coming.
Yes.
It's coming now?
Yes.
Yeah, now we can see the video. Please start from the beginning.
Yes. So I'm moving to the next video.
Sir, can't hear sir, anything.
Huh? Is it shared now, the second video?
Yes. But sound is not there.
Yes, yes, it will be there.
Make it full screen.
Okay. Huh.
I think Rudra, the audio is not coming.
Yes.
We were able to see the video, but we could not listen to the audio. Maybe you can just give the short commentary on the video.
Achha, you are not getting the audio, the video,
The audio is
embedded
not
audio, you are not getting that?
We are not getting the audio, but we can see the video. Now also we can see the
Okay, okay, now I'm commenting. Yeah.
Sir, please start from first video, sir. We can't hear anything.
No, you are not able to hear the video.
Exactly.
Rudro,
The sound of
Rudro,
the
they are
video?
requesting Rudro, they are requesting you to start from the first video. So the first video which you
Okay.
played and give a commentary on that, then move to the second video.
Okay. Got it.
When you are sharing the screen, there are two buttons in below. So one is for optimizing and one is for the audio. If you click that button, the audio will come.
But I don't find any. Okay, this is a phacoemulsification machine, and this is a peristaltic machine. This is the photo of the machine, and you can
Please
see how.
make it full screen, Rudrada. Go for.
Yeah. You can see a machine, how a machine starts. Yeah. The second video will show the details. This is just I'm starting the machine.
এটা লুটোচ্ছে
Here, the assistant is setting up the machine. He's attaching the handpiece with the phaco machine, and she is holding the phaco probe handpiece in her hand, and she is attaching the aspiration irrigation pipes with the phaco machine with the cassette. And she is now attaching the cassette in the machine console, in the phacoemulsification machine console. Yeah, she's attaching the the pipe with the BSS bottle, and the cassette is attached to the phaco console. Now there are two steps. One is a priming and one is a tuning. Priming is the cleaning. Basically, it's the cleaning of the system. It's a cleaning of the system. The water will go through all the channels through which the water can go, and this is the priming. This will take few seconds, and the next step is the tuning. Make sure that the handpiece is in the level with the machine. Yeah, now the priming is completed, and now it's the tuning. What is tuning? Tuning is the charging of the piezoelectric crystals that is situated within the phaco handpiece, through which we can convert a electrical energy to a ultrasound energy. That's the function of tuning. Now the machine is primed and tuned and it's ready for use. Now I'm going to the next video. Yeah, in this video, you will be able to see the different parameters that are used in a phacoemulsification process. These are the different modes: the scalp, the chop, the quadrant, and the epinucleus. And you can compare the different parameters that are set in aspiration, vacuum, and power in scalp, chop, and quadrant and epinucleus. For example, you can see in a quadrant it is 36,445. This is an example. This can be changed according to the need of the surgeon and the grade of the cataract. From the panel, you can see there are different modes that you can also change from your foot switch also. Next, I will go to the irrigation or aspiration. That is also having two modes, or I can say three. One is a cortex. That's for the aspiration of the normal cortical matter. This is the cap vac mode or the capsule vacuum mode, through which in this mode, it's used for cleaning of the posterior capsule and the equator. And third is a viscoelastic mode. This mode is specially used to clean the last cortical matter or the viscoelastic materials after the lens is implanted. And for example, here I have set the aspiration and vacuum into 35 and 380. But in CapVac, you can see the all are lower down. Aspiration is 6 and vacuum is 10, for example. And for taking out of the viscoelastics, here it's set 35 and 450. Now I will see the change of panel with change of my foot switch. For example, the foot switch 1 is for irrigation. The foot switch 2 is for aspiration and irrigation. And foot switch 3 is for aspiration, irrigation, and application of power or ultrasound. Nowadays, all the PGTs are very much familiar with phacoemulsification machine. And I think most of the PGTs, before passing out their MS or DO examinations, they usually get to do some phaco. So I think they're quite familiar with these things, steps 1, 2, and 3. In step 1, you see what happens. This is irrigation, only water is coming out, and this is built of a vacuum. And third is the emulsification, where I give power. This is irrigation, this is vacuum, and this is power. That is the real emulsification. And now I will give some idea about the phaco handpiece. You can see the phaco handpiece. This handpiece consists of a this part is the phaco handpiece, which consists of 6 piezoelastic crystals that is charged by the electricity that comes out in the machine, and that gives the ultrasound that comes out of the handpiece. And this is the sleeve. This is a yellow colored sleeve, and inside the sleeve there is a tip. Through the tip, the ultrasound energy is transmitted into the nucleus. And on a close look, you can see that I'm using a 30-degree Kelman tip, and this is a silicon tip, and this part is introduced into the anterior capsule to the main port. Now you can see the aspiration irrigation cannula. Aspiration irrigation cannula, there are 2 types of aspiration irrigation cannula. One is a coaxial cannula, but the cannula I'm showing here is a bimanual cannula. When we learned phaco some 20 or 18 or 20 years, 18 years back, on that time, only the coaxial phaco IA cannula were used. And as you can see, you will be able to see that if a senior person does a phacoemulsification, he will use a coaxial phaco IA cannula. But nowadays, for the last 12, 13 or 14, 15 years, this has become popular, and I think this is better for the beginners to learn and easier also. One is a irrigation, another is an aspiration. You see, I'll use the foot switch to show you. Okay, my last video about the chopper. Yeah. Yes, you will be able to see this is a table layout specifically for a FECO. And basically, there are very few instruments that are needed for a FECO emulsification machine. You can see here. Most of the instruments are dealt by Dr. Purban and Dr. Somadip. I will tell few words about the chopper. You can see. Yes, this is a chopper. I think it's not in focus. I'm trying to. Yeah, for your exam purpose also, this chopper is very, very important, because sometimes in the tension of giving exam, some students mistake a chopper by a dialer or a dialer by a chopper. So how to differentiate a chopper and a dialer? First, I have a tip. You put the chopper tip in front of your index finger and see whether it's a sharp one or a blunt one, whether it's a larger one, whether it's a small one. The basic difference is, in case of a dialer, it will be a short, it will have a short stump and it will be blunter. But in case of chopper, it will be a sharp one and a longer one. Though there are different types of chopper, there are sharp choppers, blunt tip chopper, Nagahara chopper, 60-tone chopper. But the basic thing of chopper is that it's a longer one. It may have it must have a sharper either tip or a part. Whether a Shinsky's hook is a blunt and short one. Yeah, you can see the tip. You can see the tip. It's a Nagahara chopper. How is a Nagahara chopper? It's a blunt tip, sharp chopper. It's used in a horizontal chopping. So in these 5 short videos, I have tried to show some aspects of what you have to know before appearing an exam. And now the session must be interactive, because there are different questions that are usually asked regarding this figure in recent exam. For the last 6, 7, or 8 years, the examiners always try to ask you something about FECO emulsification. And if a student is scoring better in the exam, certainly he will be asked about the FECO emulsification handpiece and FECO emulsification modes and all those things. Now I will request the moderator to ask any question regarding or discuss about some points. Over to Dr. Shuman and Dr. Tania. I want to tell shortly something about management of PCR that are very much asked in exam.
Thank you, Rudra. Thank you, Dr. Ghosh, for your nice video presentation. Particularly, this is helpful for the students.
Dr. Shuman, your audio is not clear.
Who are not very much used.
Hello, sir. Am I audible, sir?
Yeah, you are audible. You are audible.
Sir, sir, management of PC rent and power operative step that reduces the PPO.
Oh, okay. First, to start with management of power operative, I mean PCR. PCR is mostly power operative. So first is identification of a PCR. So it's very important if you diagnose a PCR in its earliest stage, and you have to manage the PCR according to the stage in which it is diagnosed. So the most common stages of PCR is during the IA aspiration irrigation, but sometimes it also happens in the stages of nuclear management also. That is very tough. That the management of PCR in nuclear management stage is tougher, but it's not impossible. It's tougher. But in case of at the end of the surgery, the PCR happens, or during the IA aspiration thing, the PCR happens. The treatment is something different. 2 or 3, it can be a different session for discussion management of PCR. I will tell you the principles of immediate management of PCR. First, if you are a student or if you are a junior, you must, if a senior is available to you, call him. Next, before coming out of the anterior chamber with your instrument, you must make that the AC is stable. How will you make it stable? Specifically with some OVD, dispersive OVDs, like for example viscoat, so that the vitreous doesn't comes out of that rent. So you have to make sure that you are not making your AC flat while coming out of your instrument. For that, you have to put your dispersive viscoelastic inside the anterior chamber. Make sure the anterior chamber is stable and the vitreous will not come out. And you take out your anterior chamber and make the planning. How will you plan? You will plan whether any cortical matter is present or not. If any cortical matter is present, whether it has gone to the vitreous or not. If a nucleus is there, if a part of nucleus is gone inside the vitreous cavity, if whole of the nucleus is there and there is a rain, or the whole of the nucleus has gone to the vitreous cavity, that will be very unfortunate. Your vitreous, your senior who is proficient with VR surgery, you have to call him in that case if the nucleus has gone into the vitreous cavity, and that's scope beyond the scope of our discussion here. These are the specifically in my experience, I have seen the examiners asking this question: what will be your management in different stages if the PCR is noted? That you have to know, and that you have to tell according to the stage. And these are the stage. What are the stage that I have told you during the figure? Whether it's during the nuclear management, whether it's in the last part of the nuclear management, whether it's during the cortical cleaning, or whether during the implantation of the lens. So this is primarily the management of PCR. And next is what Dr. Tania has asked: how to prevent PCO. How to prevent PCO from paraoperative steps. First of all, there should be a very, very, very meticulous PC cleaning, very, very good PC polishing, along with cleaning of the equatorial things. And your capsule should be round. The anterior capsule should cover a part of the lens also. And it's better to use the lens that prevents PCO. Okay. Dr. Tanya.
Thank you, sir. Nicely explained. Any question from audience?
I think already one question is there, that is for Dr. Shoumo regarding the superior rectus holding forceps. They have told it properly. Actually, the distance from the tip to the bend is around 7 millimeters, which matches the distance from limbus to the superior rectus insertion. And regarding my view, regarding the capsulorhexis forceps, there are another 2 types of rhexis forceps is available. One is Haldipurkar forceps, which is almost looking like a Vannas scissor, but the tip has a rhexis forceps inbuilt over there. And the second one is a microrhexis forceps. And other than this, there is a system in built with some FECO machines which can used for capsulorhexis. So these are the questions that can be asked during examination.
Yes, sir.
And to Rudroda, one questions in my mind that is important for the students regarding the two systems of FECO pump, the Venturi and the peristaltic. If you just give in a short, and what are the advantage of peristaltic versus the Venturi, or the Venturi versus peristaltic?
Okay,
and also that will be helpful for them.
Okay, as you mostly see, peristaltic machines are used. In peristaltic machine, there is no need of a gas, but in case of a Venturi machine, there is a need of a gas. But there is a myth that peristaltic machines are safer than Venturi machines. To some extent, it's right. But if you are an expert, a Venturi machine works better in your hand. For using of a Venturi machine, you need some gas. That's the one thing. That's the difference between a Venturi machine and a peristaltic machine. And during the effectivity part, it's also you can overcome that with practice. This factor that in peristaltic machine you can build the vacuum with your step with the control of your footstep. But in case of Venturi machine, your footstep, with the use of your footstep, you can give the maximum rise of your FECO power and vacuum. So Venturi machine and peristaltic machine both can be used in their with their advantage. But for beginners, I will prefer them to use a peristaltic machine, and after you do a few thousand cases, I think then Venturi machine will be better in your hands. That's my way. And another thing I want to tell regarding Dr. Shuman's question regarding the superior rectus holding forceps. Yes, it's a practice that we always start our surgery with a superior rectus, with the hold of a superior rectus. But it is better as soon as you leave using a superior rectus. But because holding a superior rectus has much problem. So after
as a skin surgeon, we also see after the superior rectus, there can be some hypertropia in some cases. Or
yes. Hypertropia is a very common problem after.
But usually for the beginners who are doing the small incision cataract surgery, manual, to hold the superior rectus is a better way to have a better exposure of the superior limbus, superior sclera.
But you have to keep in mind that after some years, you have to leave that habit.
Now, I ask Professor Ashim Ghosh or Professor Manoj Banerjee sir or Mousumi madam or Shambhodudha, please enlighten with your questions which can be asked during examination from these instruments, particularly the non-FECO instruments, Rexis forceps, SICS blades, hooks, and the choppers, and also from the FECO tips. And one questions in my mind, Rudroda, you didn't mention, there are two types of tips, because FECO tips are sometimes given in the examination.
Yes.
One is a straight tip and another is a curved tip.
Kelman tip.
Kelman tip. So Asim sir, please.
No, the speakers have presented very well. But the PG education is the examination had to pass, not to recapitulate the experience of a particular surgeon. And this is we know the basic instruments which are used, that has been enlisted in the textbook, that should be very much well known and to describe, because the superior rectus holding forceps is done in the beginning stage of SICS. So we have to say always we have to use this. After passing MS, you have to go outside to do the cases, to accumulate your experience, and then to say that I am not using. There may be complication definitely, but that this should not be answered in your questions. And the examiner also should not ask in this way, because we have got some experience, so that the authentic points of use of the instrument should be borne in mind. and that should be answered. One in related to that, the Somo has described the where speculum. It is examination of the blepharospasm. But blepharospasm is a condition where you cannot place the eye speculum as your choice. Always it should be in the children under general anesthesia with the descemeris upper eyelid retracted. Or in the adult also, you have to see the upper fornix, which is helpful by this. So in this manner, the examiner will ask the relevant questions which are very much done in the really practical cases we are facing. So in this way, we have to proceed. And also there is a debatable questions of direct and indirect Simcoe cannula, so that we have not to very taxated with the which one is identification for direct, which one identification for the indirect. This is the bio cannula that can be used for proper washing of the cortical matter and the viscoelastic materials. And also the PCR, you have to ask in the theory question. Definitely practical it can be asked. But before that, they should know where the PCR have a got to chance to develop. Where the conditions where we cannot develop PCR, identification of the capsules, identification of the posterior capsule, identification of the irrigation by a cannula to irrigation aspiration cannula underneath the anterior capsule proper way, and then suction to be done, and always viscomate in the last part of the phaco procedure. These are the tips that has to be known by the our beloved students. They're very, very early stage of exposure. They should definitely get experienced after passing from here. This is my way of thinking in this PG webinar. Dr. Manush will say something.
Thank you, sir. Thank you very much for your inputs. Now I request Manush sir to say something about this session and ask some questions or relevant topics which are to be discussed.
No, I think the important parts are already been discussed, and the more important, in my view, is not the individual instruments, because we usually do not give those instruments in MS examination, because only one instrument is to be given, and for that, for MS students, usually those non-phaco those instruments usually they are reserved for the UG examination. Except for the chopper and other things. But more important are the phaco-related instruments, which Dr. Ghosh has nicely described, and they are more important. But definitely, there is. I don't think there is any scope of asking the priming and all those setting and all those things, because the phaco machine cannot be present in the examination in the examination hall. It's only those tips and the cassettes and the tubing and all these things will be there, and of course the chopper and sleeve, and then anything can be asked regarding the phaco procedure. Otherwise, it's fine.
Thank you, sir.
Thank you.
Thank you very much. Now I request Moshmi Madam, HOD Bardhaman Medical College, to ask some questions. Or Moshmi Madam, please.
Madam, unmute yourself.
Hello, am I audible?
Yeah, you are
Yes,
audible.
madam. Yes.
Already the speakers have explained very elaborately, both the speakers, and Oshinda and Dr. Manush has already given some practical tips. Rudra, I will tell you, you just enlighten the students regarding surge, your phacoemulsification.
Yeah, surge is a condition where there is an imbalance between the fluid going out and the fluid coming out. So sometimes surge happen. In some years back, in the primitive machines, surges were very much present, but nowadays with the modern machines, with the modern softwares, surge is reduced. With the proper setting, The first thing is the proper setting, number one, and number two is proper wound construction. The wound should be snugly constructed so that the water is not coming out from the main wound or the side ports, and the machine should be the parameter should be set according to the need of that case. So these are the things that will prevent surge.
Thank you. Thank you.
Now I asked Shambhuddha sir for giving some light on vitrectomy, particularly on the anterior vitrectomy, and what parameters should be used and how to clean the vitrectomy cutter. What questions can be asked from the vitrectomy cutter?
Firstly, thank you, Shuman. I firstly thank OSWB and I thank all the presenters for very nice and concise presentations. Now, I must remind the students that unlike undergraduate examination, in postgraduate examination, the questions are usually not asked very flatly. Usually the questions are asked to assess the comprehension of the student so that a student can approach a case clinically when he or she will be doing a surgery. Like one very important, what Professor Ashim Ghosh has said and Professor Manush and Professor Maushumi has also said, that like suppose you are getting a phaco instrument, whatever phaco instrument you are getting, it is very important to learn about the fluidics. So it's not a simple question like what is rise time or what is flow rate or what is how to set the vacuum. It's more important that what you will do if there is less followability and why. So it's always we try to assess the comprehension of the student, that how he will apply his knowledge or her knowledge about the flow rate or about the rise time or about the vacuum. So that is very important. You should not expect a very flat direct question what you got in your undergraduate examinations. And everywhere, like even if you get like a Simcoe cannula, I think the other methods to maintain anterior chamber, that becomes important, and the examiner can go to other methods and can ask questions on other methods of anterior chamber. So this is how usually the examiner goes, the examination goes on. And if the student cannot, sometimes during examination the student cannot get the question properly, then only the examiner goes to a more straightforward question like what is flow rate. Like this is only to give some clue. These flat questions are only to give some clue that what is expected from the student, but the student should be prepared on practice-based questions in instruments also, in everywhere, in Viva VOC also, and in instruments also. The students are expected to get a practice-based question. Like anterior vitrectomy, what Dr. Shoman Mukherjee was asking, it's very important that how you know that your anterior vitrectomy is complete. What are the methods that you can how you can assess that your anterior vitrectomy is complete, and why it is important? Why, if some amount of vitreous is there, what can be the complications that can occur in future? So this way the questions go, so that the ultimately we try to assess the comprehension of the student. Thank you.
Thank you very much. Any questions from the students?
Students have, Shuman, few students have charted. Please see the charts. And if there is any question on the chat box, please answer them.
Tanya, if you find any question in the chat box, please discuss those questions, because I don't know why there is no questions in my chat box.
But what is the significance of the different colors of the FECO sleeves of a
Yes.
particular machine?
Doctor has asked this question.
Dr. Rudra.
Yes. Yeah, there are different types of sleeves in, and we know that there are different type of incisions that are done in phacoemulsification. For example, it can be a 2.8, it can be a 2.6, it can be a 2.2, and some cases in microphaco it can be a 1.8. And these are those tips signify the different types of sleeves, different types of sizes, and sometimes on the manufacturers also. And if regarding this point, anyone want to add anything? These are the things that I can give regarding the colors of the sleeves. Like the colors of the blades, there are no standardized color of a blade, because one side port can be yellow, one side port can be blue, one side port can be green. But in case of tip in a particular machine, the different colors ports are denotes the different sizes.
Sugatopal has asked one question. It is all PGTs know this, and all PGTs should know. He has said that what are the different types of fluids that can be used during FECO? Hello.
Yeah. Should I tell that?
Yes. For you.
Okay. Usually, we use, due to some other factors, we use Ringal lactate, but the best thing is of using a balanced salt solution or BSS, because the things that are the constituents of balanced salt solution or BSS is more close to the internal milieu of the eye, which is not present in case of Ringal lactate. So widely used is Ringal lactate due to financial or other issues, but always it's better to use a balanced salt solution or BSS as a FECO fluid.
And never use normal saline, that will cause endothelial damage and totally spoil the eye. One question, Rudra, regarding the viscoelastic substance, kindly just mention different types of OVDs that can be used.
That's a very important question. OVDs or viscoelastic devices are mainly of two types, but it can be classified into other types also. Mainly one is dispersive, another is cohesive. And there are some also which are dispersive and cohesive mixed. So what is a cohesive? Cohesive viscoelastic, it maintains the space. It maintains the space where we need to maintain AC or the anterior chamber. We want to need a cohesive viscoelastic. But when you want to coat something, especially the endothelium and the PC posterior capsule, we need a cohesive viscoelastic. So what's the basic difference between a cohesive and dispersive viscoelastic? In dispersive viscoelastic, there is a thing called chondroitin sulfate that is added, and that makes a cohesive viscoelastic in a dispersive viscoelastic. A specific use of a dispersive viscoelastic in case of where there is a chance of endothelial damage, or there the count is near to the critical count of the endothelium, or where there is a small rent in the posterior capsule and you need to further do phacoemulsification. There you need a dispersive phacoemulsification. These are the main two types. And sometimes soft cell technique is another technique where we use both dispersive and cohesive viscoelastic in the same go. That's known as a soft cell technique.
Thank you very much.
Sir, one question from student: in which condition reverse Simcoe is used for Purban? In which condition reverse Simcoe is used? One question from chat.
I think, Madam, Sir has already said that we should not get into the details of a direct or an indirect Simcoe, but as far as my knowledge is concerned, reverse Simcoe is used depending on the surgeon's preference of which hand the surgeon is, comfortable doing the suction. If the surgeon is comfortable doing the suction in his left hand and holding the Simcoe cannula in the right hand, then the conventional Simcoe will be used. If the surgeon is not comfortable using the left hand for the suction, then he will go in for the reverse synchro. That is what my knowledge is concerned. But if senior people have got any other answer, then
no, this is the exact answer. Thank you, Burban. This is the exact call. Which is comfortable with the right hand suction, they use the reverse synchro, or we usually prefer the left hand suction.
Thank you, sir.
So now I am requesting to our chairperson to conclude the session, Dr. Ashim Kumar Ghosh, with vote of thanks.
Manish is not here, no?
I'm there, sir. I'm there, sir.
Oh, okay.
Manish, do you want to add anything? You and Anuradha.
No, Sumanda. I think we had a very good discussion. Now the students have understood that what type of questions are important. They can always go ahead and read those topics.
Thank you very much for the nice discussion that has been done today's OSWB PG education program. Thank you for our co-chairperson here, Professor Manush Bandyopadhyay, Professor Sambuddha Ghosh, and also the moderation part by Dr. Suman Mukherjee, Associate Professor, Malda Medical College, and Dr. Tania Rai Bhadro, and also the Professor Moshumi Banerjee. Sorry, she has told that she will leave after 9, but still she is present here also to deliver one important question. Sarge, definitely that many questions or talks coming, Sarge, flow rate, and this should be known, the specific few parts of FECO. And definitely it is a very good discussion for the students who will appear for final exam and who are also reading in the second year, third year, first year. I definitely there will be another day for discussion of the instruments that has been left behind for glaucoma and also squint, etc. Dr. Shuman definitely will be invited for telling regarding this. And also thankful to Anuradha and Manish, with the beautiful coordination and also successful discussion, and also the webinar that has been happened with the help of Shipla. And finally, I conclude there is a Shipla has helped us very well. We are indebted to Shipla from OSWB on behalf of we usually convey many thanks to them for arranging such type of IT parts, and also the helping this webinar to be happen in proper way. And we also discussing on PG education committee chairperson. We are usually likening to celebrate one or to discuss one physical meeting on glaucoma workshop that has to be done in Araio in the month of March. Dr. Manish and Dr. Moitri and our faculties, they will participate for the workshop and training of the PGTs, mostly on Sunday. All the HODs are invited to participate in this, and all the students with. Thank you very much. Today, this is the end of the session, and thank you very much. Good night to everybody.
Thank you, sir. Thank you
so
very
much,
much.
sir.
Thank you, sir.
Thank you.
Thank you, sir.
Good night, everyone.
Good night.
Thank you, sir.
Thank you.